used to be the most common cancer that affected the gynecologic tract in women up until we started using pap smears for early detection of precancerous lesions that we could treat before they developed into cervical cancer. Cervical cancer is a cancer from a part of the uterus called the cervix, which is the entryway into the uterine cavity.
Cancer cell is a cell that has gone rogue, pretty much. So it's a cell that is trying to get as many nutrients as it can from normal cells in the environment, is rapidly dividing, is quicker growing, and it's a cell that there's something that went wrong in the DNA. And that cell has the instinct to keep on dividing and growing and making more of itself at expense of normal tissues. Cervical cancer tends to present with abnormal bleeding, abnormal vaginal discharge, and the abnormal bleeding may include bleeding after sexual activity or bleeding after any contact is made with the cervix, usually at the time of sexual activity. Patients may also have pelvic cramping and pelvic pain.
Cervical cancer is largely caused by a virus called the human papillomavirus, or HPV. HPV is unfortunately very common, with the vast majority of women having an infection with this at some point in their lives. We don't totally understand why some strains seem to stick around and cause cancer and other ones seem to be cured naturally by our bodies, but we do know that that's the initial instigating event, probably years before the actual cancer diagnosis occurs. Some patients are at particular increased risk for cervical cancer, and those can include women who have other reasons that their immune system is suppressed. So such as patients with HIV or patients who've had organ transplants and are on immunosuppressive medications, those patients should be screened very frequently and should talk to their gynecologists as they're at higher risk of cervical cancer. Smoking can also potentially increase your risk of cervical cancer, so while we encourage all women not to smoke, if you are a smoker, please be sure to get your pap smears.
Typically, when we get ready to see a brand new patient, we gather any outside records that may be relevant to that patient's care. So that would include a pathology report, so an area that was potentially biopsied that was a concern for the cancer, any imaging, so a CT scan, a PET scan, or an MRI that was done by their local doctor that showed concern for cancer, and any family history information that would be relevant, like first-degree relatives with cancers, any blood tests that may be relevant to, for example, a tumor marker that would be potentially elevated when we see cancer.
The initial visit usually entails getting to know the patient, getting to know what they understand thus far. Usually they're referred, having had a biopsy done before, or they may be referred for abnormal bleeding and have been told one thing or another. We take a detailed history from the patient, including past medical history, surgical history, even social history. An examination is done, and this is usually a thorough head-to-toe examination. If a patient has not even had a breast exam recently, then this will be done as well as the pelvic exam and the remainder of the systems. If the patient comes in with abnormal uterine bleeding but has not had a biopsy, then one of the things that we might do is get consent for performing a biopsy and perform the biopsy within the office.
So if your cervical cancer was diagnosed by only a small biopsy in a doctor's office, then your gynecologic oncologist might recommend a larger biopsy or excisional procedure, which could be called a LEEP or a cold knife cone. These procedures can be done sometimes in the office, but frequently in the operating room, and they allow us to get a better sense of the size of the cancer and the depth of its invasion, which will allow us to triage your treatment specifically to you. After your biopsy, the tissue will go to the pathologist, a doctor who looks at tissue under the microscope to make a diagnosis of cancer. If that tissue looks microscopically like it has cancer, you'll see the gynecologic oncologist to discuss a hysterectomy.
Well, there are two broad types of cervical carcinoma. There's squamous cell carcinoma, which basically arises from the squamous epithelium that lines the cervix. And then there's an adenocarcinoma that is derived from the endocervical glands. Both types are, for the vast majority of cases, caused by HPV, the human papillomavirus.
In terms of determining the local extent of the disease, at our institution we have very powerful MRI machines that allow us to really determine the local extent of the disease. Has the cervical cancer affected the rest of the uterus, the vagina, the bladder, the rectum, as one way to sort of accurately stage the cancer and allow us to formulate a plan of attack so that we can get rid of the cancer.
So cervical cancer, like most other cancers, are staged from stage 1 through stage 4. And stage 1 cervical cancer is disease involving the cervix, and it depends on how extensive the disease is in terms of the size, whether it's going to be a 1A or a 1B. A stage 2 cervical cancer suggests in the case of the disease spreading outside of the cervix and involving the vagina or the tissues beside the cervix called the parametra. Stage 3 cervical cancer involves the lower part of the vagina or disease that has spread to the side wall of the pelvis. And stage 4 cervical cancer could be disease that involves the rectum or the bladder, which is stage 4A, or stage 4B, which is more distant disease.
So for early stage cervical cancer, our goal is to be able to remove the cancer if possible, so that we can make sure that we've taken it out before it has a chance to spread. I mean, options for treating cervical cancer could be as simple as a local excision of the cancer, where we just cut out the area of the cervix that's affected by the cancer. It could be as extensive as removing the entire uterus and the cervix with the tissues around it to make sure that the cancer has not spread beyond the uterus and the cervix. And it could also be tailored where we would just remove the area of the cervix with the tissues around it, preserving the uterus and the ovaries, so that young women who are interested in potentially having children later on could then keep that function, all the while treating the cervical cancer.
At the time of surgery for cervical cancer, what is commonly done now is what's called a sentinel lymph node biopsy. So the mass or the area of the cervix is injected with a special dye, and then the surgical procedure is performed looking to see the first lymph nodes that dye that was injected in the cervix drains to. And those first lymph nodes, if they're involved with cancer, are thought to be representative of spread of cancer outside the cervix, but also may limit the need for more extensive evaluation of the pelvic lymph nodes. If those lymph nodes are negative, then it's usually more reassuring that the cancer has not spread outside the cervix. If those lymph nodes are positive for cancer, then a full lymphadenectomy should be performed to complete the pelvic lymph nodes as well as assess the periaortic lymph nodes.
When treating advanced cervical cancer, we treat this with a combination of chemotherapy and radiation. The radiation is given 5 days a week, every day for 5 weeks, and the chemotherapy is given weekly, and it's a small dose of chemotherapy that is used to make the radiation work better. The radiation is delivered to the pelvis and to the cervix. It can cause some frequency of urination, diarrhea, some skin changes. These are all symptoms that we can help you manage with medication and other preventative measures. So sometimes when our cancers recur or continue to progress despite our best treatments, we think about other measures we can take to help preserve or maintain your quality of life. Sometimes it's called symptom management, sometimes it's called palliative care. And the goal of palliative care is to help maintain your quality of life and allow you to continue to do some of the things that you enjoy most and help you cope with potentially a new way of living, but also do our best to control the disease for as long as we can.
With surgery, the biggest risk is obviously harm to the surrounding organs. We can, in some cases, affect the nerves that irrigate the bladder. But we have now perfected techniques where we can actually isolate those nerves and set them aside so that we can really minimize the risk to the bladder itself. From the removal of the lymph nodes and radiation, there could be swelling to the legs, what we call lymphedema. But we're hoping that now, with our techniques of using sentinel lymph node resections and really tailoring your radiation, that we would minimize the risk of that complication.
Risk for radiation may include one common thing that happens is fatigue. Some patients may have a bit of nausea. There may be loose stools. Those are some of the common complaints, along with dysuria or burning on urination. Risk associated with chemotherapy include having a weakened immune system and having a higher risk of infection. There may also be fatigue. There may be nausea, but this is something that we usually can control well, and patients should never vomit with some of the modern ways we give chemotherapy, along with the drugs that we give for nausea and vomiting. So unfortunately, there is the risk of recurrence after patients have been treated upfront for cervical cancer. And as such, they're monitored closely. A typical follow-up is every 3 months for the first 2 years, every 3 to 6 months maximum for the first 2 years, and then every 6 months from year 2 to year 5, and annually thereafter.
At Stanford, we use the most recent clinical trial data and the most recent surgical updates to make sure that even in the time that you're scared of your new diagnosis, that you're going to receive the most updated, innovative treatment. We hope to get everyone into remission, but regardless of the nature of your clinical course, your gynecologic oncologist will be there for you to follow you